we are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around that 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource-poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country. But that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with our YouTube program, which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now, we have 14 fellows who have joined. So this is something. But then again, the reach is limited. To take it forward, we started with our MedEClasses, which was our online portal, which takes it beyond the routine classroom to beyond so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to take the implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the MedEClasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working was like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was a Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there, and you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the DKA management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us. So when we talk about hypocalcemia, the most common cause is vitamin D deficiency. But what we are concerned from an endocrinologist perspective is PTH problem. The most important investigation in a child with hypocalcemia is phosphorus. Everybody with hypocalcemia should have low phosphorus. If you have a high phosphorus, think of a pseudo-hypo, hypoparathyroidism, or renal insufficiency. Second is PTH. If your PTH should ideally be above 70 in somebody who has hypocalcemia, a PTH which is less than 70 with hypocalcemia is inappropriate response. Everybody should, of course, vitamin D becomes important, and important would be urinary calcium. If you have less calcium, urine calcium should be 0. If you are having hypercalciuria, that is calcium sensing receptor defect. So approach, as I said, starts with phosphorus. But before that, you want to exclude magnesium, albumin, and phosphorus load. If phosphorus is low, think of vitamin D related causes, look at 25-OHD and then VDDR1 and 2. If it's high, think of renal failure or PHP losing creatinine. And remember that calcium and PTH have a log linear relationship. If your calcium is low, PTH should be high, above 70. This is PHP or secondary. If PTH is inappropriately low or normal, this is hypoparathyroidism. Remember, PTH is a very labile hormone. If you do not transfer it in ice, you will have a problem in terms of assessment and you will have a falsely low level. So start with the cases, Dr. Alapan.
So I'll start with the case of a 4-month-old boy presented with nephrotic syndrome and a calcium of 7.2 milligram per DL, which is low. So now the child is asymptomatic, and let's see what our interpreter gives regarding this.
So what we'd like to know here?
We'd like to know the albumin level in this case because the child is a nephrotic syndrome case, and before
the albumin here was low, of course. And you
So,
found the albumin of 2.2.
0.2.
And how will you correct this?
So every decrease of 1 milligram of albumin, the calcium should decrease by 0.8. There is a formula about this. Corrected calcium equal to measured calcium plus 4 minus albumin into 0.8 milligram per
This
dl.
is normal. If you correct it by around 1.6, it becomes 8.8. So this is not hypocalcemia.
Calcium. So moving on to the next case, a 4-year-old girl child presented with tetany, symptoms of hypocalcemia. Ionic calcium is 3.1 milligram per dl. So in this case, this is a low calcium. So we should look for the phosphate level, as sir has already described. The phosphate level in this case is high. So before labeling somebody as a PTH related disorder, we should always first look for the creatinine level in these scenarios.
What we've done in this algorithm is a bit different. So if you look at it, rather than, so we don't want this mistake to happen at all. So we are not asking for phosphorus at an early stage. What we are saying is that if you are hypocalcemic, first tell us what the creatinine is, so that this mistake will not happen. So what happened in this case was phosphorus was high, PTH was high, labeled as pseudo hypoparathyroidism. But if you look at it, the first thing which comes is creatinine, so that immediately this is not missed out. Second thing which will come is magnesium. Then it will come to phosphorus, so that you are not confused at all. So this clearly is a case of renal insufficiency, which was misdiagnosed as PHP, which is unfortunate in that regards.
So again, the next case, the 1-year-old boy child presented with seizure with ionic calcium of 3.2, a low calcium level. And now the phosphate level is on the normal range. And the PTH is low and labeled as a case of hypoparathyroidism.
So again, do you agree that this is hypoparathyroidism?
So before labeling someone as hypoparathyroidism, we should look for the other ions like magnesium. We should see in this.
So that is why if we look at the algorithm, what it is asking is that it is asking after creatinine normal, asking magnesium. So if you remember our algorithm, we are saying exclude magnesium, phosphorus load and renal failure. So they are being excluded there only. So that's why we are asking it early. So
there is no response to the IV calcium. The magnesium level was low in this case, which having a TRMP6 defect and requires
TRMP6.
It's a magnesium transporter present in the distal tubule.
In the intestine as well as the kidneys, both places. So these are the most refractory cases. And you remember there are two siblings who are taking 10 grams of magnesium sulfate and they're doing fine. So this is a rare scenario, but then interesting one. Carry on.
So moving on to next case, a 3-month-old girl child presented with seizure, ionic calcium of 3.2 milligram per dl. So again, a case of hypocalcemia with symptomatic hypocalcemia, and phosphate level is low in this case, 2.2 milligram per dl, and PTH level was also low in the scenario.
So labeled as hypoparathyroidism. Do you agree?
Sir, we have to always see for also the phosphate level in that in this scenario. In cases of hypoparathyroidism, the phosphate level should be much higher. So more likely a case of vitamin D deficiency in this scenario.
So phosphorus is a biomarker, the bioassay for PTH activity. If your phosphorus is low, it means there's no way your phosphorus will be low unless PTH is there. Let's put it in a very simple term. So it means that PTH, I am not going to believe this PTH report. And if you go by algorithm, what it is saying is that you look at the ionic calcium, you can start the algorithm now.
Yes.
So calcium is on the lower side, creatinine of course is normal. It will ask creatinine, it will ask about magnesium then, and magnesium was also normal. So now the issue would be what is the phosphorus. So after creatinine and magnesium, it will ask for phosphorus, which is low. So we have excluded, if the phosphorus is low, we don't ask for PTH. We will go for vitamin D. And if we had done this interpreter, we would get the right result right away. And this was a vitamin D deficiency. If you want to send PTH, either send the patient to the lab. Rather than going to a collection center, he goes to the proper lab or he takes the sample in the ice. The collection person has to do that, which is rare. So this is a major issue in terms of PTH.
So yeah, probably the PTH low is due to the transport defect in that scenario. And again, the next case of 1-week-old boy presented with symptomatic hypocalcemia, seizure, and phosphorus level in this case is high. So we should always see for first the creatinine level, whether high or not. The creatinine is normal in this case and PTH is high.
Yeah.
So
this looks like a pseudo hypoparathyroidism.
No, we should always before labeling someone as pseudo hypoparathyroidism, we should look for the vitamin D status also, because sometimes the vitamin D chronic deficiency can also present like a.
So this is a very important message which is there. So if you have long-standing vitamin D deficiency, there will be induced PTH resistance. So this looks like pseudo-hypoparathyroidism, but I will not be very confident. 1 week, very rarely for pseudo-hypoparathyroidism to present. So if you look at what is clearly mentioned, this is not 1 week actually, this is 11 years, some mistake there. So anyway, it recommends 25 OHG levels. But if you look at the child, he has other features. There is cataract.
There is brachycarpia. There is calcification is present in the below the skin.
So this is a classical case of pseudo-hypoparathyroidism. So this is an older child, but even there, before you make a diagnosis, vitamin D becomes important. Yeah. Carry on. So hypercalcemia is a rare scenario. And again, the most important thing here is phosphorus. Anybody who has hypercalcemia because of hyperparathyroidism should have a low phosphorus. If you have a high phosphorus, this is PTH independent, and the most common is vitamin D toxicity. Remember, vitamin D toxicity will be more likely to cause nephrocalcinosis because they have lesser absorption of calcium. Other rarer causes include granulomatous disease. The classical feature is birth asphyxia with nodules which are going to produce 1-alpha hydroxylase, or you can have other things like sarcoidosis rarely. The other thing to look at PTH, everybody who has hypercalcemia should have a PTH less than 20. Hypocalcemia, PTH more than 70. Hypercalcemia, PTH less than 20. Inappropriately, normal PTH in hypercalcemia is also high. So, hyperparathyroidism, your PTH will give you a clue. Other is hypercalciuria, and vitamin D, of course, becomes important. If you have normal vitamin D and high calcitriol, that is 1-alpha hydroxylase, issue from that perspective. The approach is PTH should be below 20. Think of vitamin D related causes. High in vitamin D excess, normal you do calcitriol. High in granulomatous diseases like sarcoidosis, tuberculosis, fat necrosis. Normal in hypophosphatasia. Above 20, look at fractional excretion of calcium. Above 1%, think of hyperparathyroidism. Less than 1%, think of a calcium sensing receptor defect. So I think the last 3 cases probably.
So 12-day-old girl child presented with irritability with dehydration. Ionic calcium is 8. So higher calcium level, hypercalcemia is there with symptoms present of irritability.
Yeah.
Now, so the urine calcium and creatinine ratio is low in this child.
Relatively low.
Relatively low.
And you have to look at the PTH, which is going to be very, very high. So a neonate who comes to you with irritability, constipation, hypertension, hypercalcemia, think of a neonatal severe hyperparathyroidism, which is a defect in the
calcium sensing receptor.
So it's a homozygous defect in the calcium sensing receptor defect. So check the calcium creatinine in the mother urine. And this is not very high because of this defect. Otherwise, it should be sky high.
So moving on to the next case, a 2-year-old girl child with abdominal pain. Ultrasound is showing nephrocalcinosis and ionic calcium is high, 7.5 milligram per DL, with a relatively high phosphorus.
So high phosphorus, high calcium. Do you think PTH will become important?
No, I think the vitamin D levels should be much more important in this scenario, and we have seen a vitamin D level is high in this scenario. So probably the child has taken too much vitamin D from exogenously.
So again, the message is if you have hyperparathyroidism, to develop nephrocalcinosis, it is going to take time. But if you have vitamin D excess, and mother in this case was giving sachet daily for 20 days, it will acutely cause this nephrocalcinosis. This is something you need to be aware of.
So moving on to the last case, the 4-day-old boy presented with seizures, birth weight of 3.2 kg with bath asphyxia, history of bath asphyxia present. And he has ionic calcium of 10 milligram per DL with phosphorus in the high normal range, 4.2.
Not low.
Not PTH is low in that scenario.
So we are dealing with a non-PTH or a PTH independent cause with a high phosphorus. Of course, now more people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is, definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MedEClasses endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.